I love you gave us a really good example of how you guys are applying AI and predictive analytics towards end of life to improve quality and total cost. What about around chronic disease management?
We do a lot for diabetes, CHF, CKD for diabetes. First of all, we try to identify people who are pre-diabetic and who are the people that are more likely to become diabetic within the next year, the next 2 years. And we try to reach out to them, reach out to their doctors and help them nudge them so they can lose weight, take the medication and so on. And we honestly seen that we slowed down the progression of people from pre-diabetes to diabetes. Actually, it was a corporate scorecard for us that we were really working at the highest level of the company. We wanted to reduce that progression of disease. Right now, we're working on CKD, chronic kidney disease. Chronic kidney disease, what we have seen from our data that, for example, these are some scary numbers. About 55% of our members, when they first have dialysis, they have it in inpatient setting. We call them crashes. They crash. They didn't even know that they have CKD. About 50% of our population, when they have a dialysis, have they even seen a nephrologist? No, they have not seen a nephrologist to begin with. The people who have a mature fistula, not even 30% before they have first dialysis. So really this screams of a couple of things. It screams that we're not really treating people with CKD, at least in our community, as well as they need to be treated. But honestly, I think this is a national problem. This is not just to Western New York. What are we trying to do? We identify a couple issues. First of all is that providers are not even coding CKD1 and CKD2. There's stages to CKD. When you get to stage 3B, what we call that the point of no return, you're going to go to stage 4, you're going to go to dialysis. If you can get them 3A, you can revert even the disease. So what we do, we run models to identify people that are more likely that have CKD 1, 2, or 3. And we reach out to the providers to say, hey, we need you to confirm this diagnosis. Then if you're, for example, at 3, we got to get you with a nephrologist. If 1 and 2, okay, we want to make sure you're managing your blood pressure first, you're managing your LDL, your A1C, and all that. Really, what we're trying to do now is slow down that progression, identify the people like we did for diabetes and we're successful in diabetes. We're trying now to do the same thing for CKD. And we want to really, for our community, slow down the progression of CKD and have less dialysis and less complications in life.